Hello and welcome. Moss Adams is pleased that you joined us for today's session, Medicare Regulatory Update, 2025 IPPS Proposed Rule. And before we begin, I'm going to play our housekeeping video.
Welcome, and thanks for joining. We're pleased to present our continuing professional education webcast series. Before we begin, please keep the following in mind. You can customize how you view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can adjust window size and placement or enter full screen mode using the controls at the top right of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons that relate to a different aspect of our session. You can download a PDF of today's slides from the Slide Deck and Handouts widget. You can ask questions by typing in the Q&A window and clicking Submit. We'll do our best to answer all questions or follow up via email. If you experience technical difficulty, refresh your browser by hitting the F5 key. Today's session offers 1 CPE credit. To receive credit, you must meet the National Association of State Boards of Accountancy requirements. You must attend at least 50 minutes of the session and respond to at least 75% of polling questions. To participate in the polls, please check the button next to your answer within the slide window and click Submit. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry if you can't download your CPE certificate today. We'll email you a copy in 2 weeks. If attending this webcast in a group, you must complete our Group CPE Attendance Sheet, available in our Slide Deck and Handouts widget to receive credit. Please have all group members sign it and send only 1 sheet per group. CPE credit can only be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. This presentation is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
All right, we have 3 great presenters with us today, all from Moss Adams. We have Eric Lucas, Managing Director, Glenn Bunting, Managing Director, and Jonathan Mason, Director. Their bios and contact information are located in your webcast console. And now I would like to turn the floor over to Eric to get started.
Hi, thanks for joining us today. Thank you, Amy. This is interesting proposed regs because I think we started out thinking that this was pretty light, but there's significant proposals here that are worth our time and discussion. And I do want to point out here that this is the proposed regulations for IPPS. They could change dramatically as a result of the comments that you make and other stakeholders make to CMS. So it's important as you go through this process to understand how this affects your entity and ensure that you're responding to CMS with any thoughts or concerns. With that, the agenda today will be discussing the payment rate updates, changes to the MSDRGs, changes to wage index, the proposals related to the DISH and uncompensated care payment, proposals related to the GME, quality programs, a brand new program proposal, transforming episode accountability model or team, and then a few other items at the end. Unfortunately, given the amount of issues we're discussing today, it's unlikely we'll have time to do questions within the presentation. However, there is a Q&A box, and any questions that are submitted during the course of this presentation will be responded to by one of the presenters subsequent to the meeting. So let's get going. Payment rates. Well, let's start with a polling question. The first of 4, Amy.
All right, thank you, Eric. So the polling questions are located right on the slides that we're presenting. So if you can't see it, you may need to hit the F5 key to refresh your console. The first one is, in the federal fiscal year 24 IPPS regulations, CMS implemented additional payments where specific social determinants of health diagnosis codes were present. Has your organization ensured it is currently able to identify and code for all patients with homelessness status? And your options are A, yes, B, no, or C, I don't know. And while you're responding, just a reminder to please click the button next to the answer you choose, and then make sure to hit that submit button so that it does record your response for CPE. And here are the results.
Okay, the I don't know is something we'll want to talk a little bit about, because not only is this a new or an update to our current payments and could mean additional reimbursement for hospitals for caring for this community that does require some additional resources. But the program is being expanded, and CMS continues to look at ways to ensure that they're addressing the social determinants of health and how it's impacting the cost of care and reimbursing for that cost of care. So it's definitely an issue that hospitals will need to look at as we go forward here. So the probably simplest part of any IPPS rate changes is to look at the actual base standardized payment rate and understand how that's going to ultimately change from year to year, because ultimately that's the one area that's pretty much static across all hospitals before we start getting it even more complicated. So let's start with the operating payment rate change. That's a 2.6% proposed increase over 2024. That's only if the hospital is a meaningful user of EHR and is submitting its quality reporting. We'll show the breakout of that in the upcoming slide. The 2.6 is a 3% market basket reduced by the 0.4% productivity cut for the year. It will result in a $2.2 billion additional payment increase over 2024 for the year. For comparison's sakes, that's a 3.1% change from last year, a reduction in the amount from last year. And if you joined us last year for this, you'll recall that at that time there was quite a lot of concern about the 3.1% increase compared to what hospitals were experiencing from the inflationary factors that were resulting in labor costs and supply costs. Immediately after the submission of the proposed regulations, stakeholders, hospital advocacy groups were quick to respond to CMS with concerns that, again, CMS was not meeting the moment. Hospitals were experiencing cost increases, and the 2.6% payment increase looks like something that we would have got on a normal year where we don't have those kind of inflationary periods. 2.6% is pretty average for if you look at the last 10, 15 years. So it's really quite a surprise, given that there was more of an expectation that the market basket would come in a bit higher to reflect the inflation at the moment. So a breakdown of the 2.6%, as I mentioned, in order to receive 2.6%, the hospital has to be a meaningful user of electronic health record software and submit its quality data. If it does not do that, it could get anywhere down to a actual payment rate cut of 0.4%. So you're going to see this slide a couple times today. Using it right now to demonstrate the overall payment construction and how that operating base payment rate that I just mentioned breaks out between hospitals with a wage index above 1 versus below 1. As you see, for hospitals with a wage index above 1, that operating payment rate is split out between a labor and a non-labor portion. The labor portion is higher for hospitals with a wage index above 1, and the labor portion of that rate is lower when a hospital has a wage index below 1. And so as we look to that next slide, you can see here's the breakout of the $7,182, where the labor portion is higher than the non-labor portion when that wage index is higher. Therefore, not being negatively impacted if that wage index is below 1. And you can see the payment rate increases across that board. To overcomplicate the question, it's not simply a matter of applying that 2.6% across. There's a number of factors that ultimately go into coming up with the hospital's DRG payment rate. And a lot of that relates to keeping the program budget neutral. So whenever there's any shift in the payment calculation that ultimately impacts a group of hospitals other than the entire hospitals, adjustment is going to need to be applied to keep everything budget neutral. And so in this case, we see last year's unadjusted rate of $4,782. We apply that 2.6 update factor, and then there's a number of factors, many of which relate to wage index, which Glenn will be talking about in a little bit here, to ultimately reduce that rate down and make it budget neutral for the program. The only other one I would point out is the operating outlier factor of 94.9%. That is standard year after year. That 5.1% reduction to the standardized payment rate ultimately funds the payments of outliers, which we'll be talking about here shortly. And here's the breakout of the capital, which is a little bit more straightforward, but again, has adjustment factors to ultimately make it budget neutral. So outliers. So in the current year, they're proposing an outlier threshold of $49,237, which is up from the current outlier threshold of $42,750. And as I just mentioned, CMS estimates outlier payments at 5.1% of total inpatient payments annually. And sometimes that goes higher and sometimes it goes lower. It's a guess. They don't roll forward that variance into the subsequent years. So they try to get as close to that as possible. In federal fiscal year 22, they went significantly over. And that started a series of pretty significant increases in the outlier threshold. In fact, the last 2 years, we've seen some pretty big increases as the threshold has jumped up in order to get CMS payments back on target. This current year is another pretty big change. It's a 15% increase to the outlier threshold, which for a lot of hospitals is going to drastically reduce what's ultimately qualifying as an outlier in the calculation. The other thing to point out here is CMS is responding to an OIG finding that the outlier reconciliation process, the process that ensures that no specific hospital is overpaid on outliers based on the cost to charge ratio that is ultimately used to make that payment versus what is ultimately finalized through the cost report. That process is going to change because OIG found that it wasn't identifying all the hospitals appropriately that are being overpaid. And so they are proposing that the change ultimately will identify hospitals that have outliers exceeding 500,000 with a cost to charge ratio in excess of 20% change will automatically receive an outlier reconciliation at this point. In addition, all new hospitals will receive an outlier reconciliation in their first years. This will go into effect starting with cost reports beginning period October 2024. So that's the end of the payment rate change. Shifting over to the MSDRGs and the clinical weighting of our payments. Their changes are pretty minor overall. The DRG weights have been updated to reflect the most recent MedPAR claim listing and the FY22 cost reports. There are 10 new MSDRGs and 3 MSDRGs that are expiring. Of those 10 new MSDRGs, 8 of them are related to spinal fusion. The 3 that are being expired are all spinal fusion. They're simply converting that 3 into 8 new MSDRGs with different diagnoses related to them. And then there's 2 others, one related to acute leukemia, and breaking that out. Ultimately, the weights shifting are consistent with past years. As you might remember from the prior year, the CMS put a cap on how much a DRG weight could decline year over year at 10%, although on the positive side, it can actually exceed that 10%. In the current year, we see 5.3% of MSDRGs actually increasing by 5 to 10%, and the 11.6% are decreasing by 5 to 10%. There's quite a few DRGs that are hitting that 10% cap on the negative side. There are 25 MSDRGs that are increasing above 10%. The top 5 are listed on this next slide. Pancreas transplant, skin grafts, abortion, arthroscopy, and malignant breast disorders all are seeing significant increases to the weights. I strongly suggest, as if hospitals are modeling what their impacts are year to year, that they don't just look at that standard weight, that they do look at how the weights on the MSDRG are ultimately changing their estimate as well. Oops. There we go. There is a new ICD-10 grouper. CMS has released the software so hospitals can model the impacts of the changes to the ICD-10. There are some new diagnosis and procedure codes. A lot of them are related to the changes to spinal fusion, and so they can adjust to the new DRGs that have been introduced. But the one that I want to point out here is the expansion for social determinants of health. There is an expansion to the diagnosis codes, similar to what we talked about at the top of this presentation, which will move a DRG from a non-comorbidity to a comorbidity, and therefore increasing the reimbursement. Last year, it was homeless diagnosis, and in the current year, they're adding a series of diagnosis codes that reflect insufficient housing, in this case, housing without utilities or working utilities, or inconsistent housing, as an area that will be flagged here for additional payment. The new technology add-on payment is a additional payment for relatively high cost technologies. This is a rotating annual listing. In the current year, CMS is continuing 24 of these previously approved technologies, but 7 are dropping off, either being incorporated into DRG payments or no longer being approved through the CMS process. 12 new technologies are identified under the traditional pathway and 14 on the alternative pathway. The CMS, the proposed regs go into great detail on all of these areas as to the expectations for all of these. CMS did also relax some of the regulations as far as how a new technology gets on that list from a timing perspective. And so we actually see a little bit bigger of a list than what would have normally been allowed. And I'm going to shift it over to Glenn for Medicare Wage Index.
All right, thank you, Eric, and good day, everyone. Many times when the IPPS preliminary rule is issued, we'll see modest changes to wage index related topics. That is not the case this cycle. We are in a different territory with respect to the 2025 IPPS rule. In this cycle, we find CMS has reshuffled the wage index deck. Specifically, we are seeing significant changes to the composite of core-based statistical areas, which then triggers significant changes to certain wage index factors. This will impact current MCGRB reclassifications, which present opportunities for new MCGRB reclassifications and non-wage index.
Did we lose Glenn? Well,
I think so.
I'm going to do my best to do this wage index process until Glenn returns. And I apologize for that. We are bringing back the chart that I showed earlier that identifies the fact that we apply a wage index factor to the labor portion of the operating base rate. That wage index is a budget neutral factor, although there are adjustments that have been made for reclassifications and the rural floor. But ultimately, that is one of the biggest factors on the operating payment rate to come up with the hospital's main rate.
I'm back, Eric.
Good, you're back.
Yep, something happened, froze up, but we'll start here with the reshuffle. CMS uses geographic area differences in the construct of their wage index factors. Geographic areas are defined in large part upon county lines. Although in the eastern part of the U.S., there could be different delineations used for certain geographic areas. Like, for example, in the state of Connecticut, they rely upon planning regions. The source of the current geographic areas is rooted in the 2010 census, as updated by various OMS bulletins over the course of time. But on July 21st of last year, the OMB issued bulletin number 23-01. And in the simplest of terms, this bulletin adopts changes to the CBSA areas based upon the results of calendar year 2020 census data. So here we are 4 years after the 2020 census was taken. Those changes are finally being implemented into the geographic areas and are proposed to be adopted into the construct of the wage index factors effective October 1st of 2024, so later this year. So if we peel back the onion of wage index a little bit, what is really changing? We have 53 counties nationwide that today are urban, but tomorrow are proposed to become rural. This change from urban to rural appears to impact 33 hospitals. Of these 53 soon-to-be rural counties, 17 of these counties are considered Lugar counties, which means they are still deemed to be urban to the adjacent county where the majority of the workers commute. This means there's truly just 36 counties that are expected to convert from urban status to rural status. It's important to note, generally, capital dish reimbursement is not available to hospitals that are geographically located in rural areas, so they could possibly lose capital dish. We also have 54 counties that today are rural, but tomorrow are proposed to become urban. This change from rural to urban appears to impact about 24 hospitals. These hospitals, the opposite would be true. They would be eligible to receive capital dish payment, provided they also meet the 100-bed requirements. So a lot of movement where certain urban counties are moving to a different urban CBSA. Just some examples. The state of Montana is gaining a few new urban CBSAs. These are all random, no particular order. There's a CBSA for Atlanta, Georgia, as an example. The number of counties that are in that CBSA appears to be about doubling. And then you get to the CBSA for Tampa, St. Petersburg, Florida. That's going to be split into two different CBSAs, one for Tampa and one for St. Petersburg. So you got all kinds of changing here that is going to impact the Medicare payment going forward. Other considerations, critical access hospitals. They're slated to become urban, or if they're slated to become urban, they'll lose their critical access status unless they apply for an urban to rural reclassification. Existing regulations provide for a 2-year period for cause to apply for an urban to rural reclassification in order to maintain their cause status. Other special hospital designations, such as if you're a sole community hospital or a Medicare dependent hospital that require rural status, those may also end if the hospitals do not apply for an urban to rural reclassifications. These hospitals should apply for urban to rural reclassification before October 1st of 2024 to avoid terminating their special status. In the past, CMS has offered up transition periods to kind of help ease hospitals into new regulatory changes. Sometimes major changes are implemented in thirds, like over a 3-year period. There's no such relief this go around. Instead, CMS just simply states that their standard 5% cap on any decrease to a hospital's wage index from its prior year wage index would be applicable. Geographic reclassifications, just a little background. With all the changes to CBSAs, let's touch upon these reclassifications and the process. Certain hospitals utilize a process, it's called geographic reclassification. They apply to be approved to use another area's wage index. In order to use another area's wage index, the applying hospital must be within a specified distance, 15 miles if you're an urban hospital or 35 miles for a rural hospital, and have wages that are different than its own and comparable to the wages of the requested area. So the wage test is shown there on the screen in terms of the 2 bullet points. What will happen is you will apply, and the Medicare Geographic Classification Review Board, or MGCRB, will decide whether the hospitals meet the criteria for reclassification. Geographic reclassifications are effective for 3 years, but they could be temporarily withdrawn or terminated. So if a hospital accepts a new reclassification, any prior ones are permanently terminated, but there's a deadline for withdrawing or terminating a wage index reclassification. For 2025, that if you are approved for fiscal year 2025 by the MGCRB, it's now 45 days from the date of display of the 2025 proposed rule. So they've shortened this timeline. In the past, it used to be, you could go into the month of June to rescind. Now the starting point is sooner, and the last business day before 45 days from this proposed rule is May 24th. So you have just a little bit more than 2 weeks to make a decision whether you need to rescind or not. You know, it's incumbent upon everybody that's listening to this presentation, or anybody that's involved with wage index, to be looking at your geographic reclassification, your wage index, all the options right now. So on this slide is a summary of the wage index factor implications and the consequences of the OMB bulletin number 23-01. You have urban counties becoming rural. You have rural counties becoming urban. You have hospitals that are reclassified to a CBSA subsumed by another CBSA. You have hospitals reclassified to CBSAs where 1 or more counties move to a new or different urban CBSA. Hospitals are reclassified and they're reconfigured due to the migration to Connecticut planning regions. All kinds of things going on. What if you're not currently reclassified, but you find it would be advantageous to do so? You typically have until September 1st each year to submit an MGCRB reclassification application. This year I looked at the calendar, September 1st falls on a Sunday, so it's likely that the deadline will be probably September 3rd, so the day after Labor Day. However, at this time, CMS has not published the exact filing date, but if you do find that you likely could reclassify and get some, get a higher wage index value, you do have some time to do that. There are a couple of geographic reclassification opportunities that originate from OMB Bulletin 2301 that should also be considered. Urban to rural reclassifications, which are not limited to wage index. So hospitals that meet specific criteria in the statute may request that a CMS regional office treat an urban hospital as rural for purposes of IPPS payment. These reclassifications are permanent until they're rescinded. You don't have to wait for a certain date. You can make the request when you're ready, and they're effective upon the date of your application. Also, Lugar counties, we kind of mentioned them earlier. CMS makes the determination whether you're a Lugar hospital. So the process is automatic, it'll occur with no action on the part of the hospital. In terms of the wage index data that we report on worksheet S3, part 2 through part 5, the wage index policies are unchanged really from the prior year. On January 26th of this year, we found that there are 3,075 hospitals being used currently to construct wage index factors from cost reports that are tied back to fiscal year 2021. There's also 69 hospitals that failed edits. They were deemed to have inaccurate wage data. Some of these hospitals may in part be included in the wage index in the final IPPS that's going to be released in August. Probably a good majority won't though. CMS has reviewed the fiscal year 2021 wage data. And if you recall, this spans the COVID-19 public health emergency. And CMS reached the following conclusions. They found that most providers had a higher increase to their average hourly wage during the pandemic year as compared to prior years. But they also admit that they don't know how they can isolate increases from COVID-19 pandemic from just normal increases. So they're just using the data as is. CMS calculates an unadjusted national average hourly rate of $54.80. And when you apply the occupational mix factors to it, it drops down by 7 cents to $54.73. An interesting thing that's going on here is CMS is, I guess you'd say, doubling down on their low wage index hospital policy. They've elected to continue this policy that they first adopted in fiscal year 2020. However, in the proposed rules, CMS is proposing to extend this policy 3 years through fiscal year 2027 to obtain adequate data intended to measure the results of the policy. They feel that they weren't able to really adequately measure the success or non-success of their low wage index policy due to the COVID-19 pandemic. So they're effectively approaching this as a reset, and they plan to measure the results over the next 3 years from 2025 to 2027. So what's this policy about? Under the policy, CMS makes upward adjustments to the wage indices of hospitals with wage index values below the 25th percentile. Last year, the cutoff was a wage index factor of 0.8667. This year, the proposed rule shows it at 0.8879, so it's gone up a little bit. As in past years, CMS is proposing to fund these adjustments by making a budget neutrality adjustment to the standardized amounts. This policy is not something that's accepted by all hospitals. There's been litigation on it. There has been a district court decision called Bridgeport And in that case, it was found that CMS's low wage index hospital policy is unlawful. However, CMS believes in this, and they're currently appealing the Bridgeport decision. To kind of close out the wage index section, I have a slide here that shows on average the wage index winners and the non-winners in this proposed rule. We have states, Indiana, New Hampshire, Alabama, Tennessee, New Mexico, Missouri. They're all going to do fairly well with this proposed rule, but then we have states, other states, California, Hawaii, Nevada, Massachusetts, and boy, Connecticut, that are really going to get hammered in terms of all of these changes that are going on with wage index. Primarily, I believe it's the CBSA shuffle that's going on. And with that, Amy, I'll turn it back to you. We have a polling question.
All right, thank you. So the second polling question, have you analyzed your fiscal year 2025 proposed wage index factor and understand the changes that are impacting its value? A, yes, B, no, or C, unsure. And then just a reminder, if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. All right, this one's going pretty quickly. We'll just do another 5 seconds. And here are the results.
All right, we kind of have a mixed set here. It's good to see 40% of everybody has been looking at this and they understand the changes. But to be quite honest, if you answered no or unsure at this point of the game, it doesn't surprise me. Again, call to action. Everybody, we need to start looking at this data and start making decisions given the upcoming, the first deadline of May 24th, if you have a current MC/GRB reclassification. With that, I am going to turn it over to Jonathan Mason to talk about DISH and uncompensated care.
All right, thanks, Glenn. So, like Glenn said, I want to spend a few minutes covering the DISH and UC payment section of the rule. There was an increase in the size of the UC distribution this year, albeit, maybe not as large as many in the community were hoping for. But uncompensated care payments are the products of 3 factors. Factor 1 is the difference between the Secretary's estimated Medicare DISH payments if they were paid at 100% DISH, less what CMS calls the empirically justified DISH payments, which is 25% of that total. So for the Factor 1 calculation, the DISH estimate begins with an anchor period. In this case, it's the 2021 data. It's then trended forward by a number of factors applied to the 2022 through the 25 periods. So the starting baseline total was $13.4 billion, and then trending that forward, the end result is $13.943 billion for 25. CMS points out that their approach in calculating these totals is consistent with previous rulemaking cycles. And just like in previous years, the Office of the Actuary intends to use more recent data that may become available between the time of the proposed rule and the final rule. So here's a view of Factor 1 from a trending standpoint since 2014. Like I said, the net result, the DISH estimate is that $13.943 billion. So after you remove that 25% empirically justified amount, the proposed Factor 1 is $10.457 billion. And so that's a $442 million increase more than last year's total. So moving on to Factor 2. Factor 2 is the factor that's calculating the change in the uninsured rate. So for calendar years 24 and 25, CMS estimates the uninsured rate at 8.5% and 8.8%. You then have to the calculation converts that actually to a weighted uninsured for the year to 8.7%. And so then after running it through the formula, this year's factor 2 is 62.14. So that's close to a 3 percentage points higher than the 24 final rule, which ultimately increases the UC pool this year. So the underlying data, the methodology used to calculate this rate is consistent with prior years. And those estimates are produced by CMS's Office of the Actuary. And again, CMS states that they may consider more recent data that may become available between the proposed and the final. So where does that ultimately leave us? The final UC pool calculation, you apply that 62.14% uninsured rate to the 10.457 billion. And that then derives an uncompensated care pool of $6.498 billion that will be distributed to about 2,400 hospitals. That's an increase of 560 million compared to last year's final rule totals. That's up 9.4%. So a decent size uptick from last year. And as you can see from kind of a trending perspective, thought it would be good to show since 2014, you can see the initial pool was 9 billion. It actually steadily declined as the rate of uninsured declined in the US, or at least what was estimated using at that time, the CBO data. There was a switch in new metrics, and as a result of the changes in kind of various factors that impact coverage decisions under the Affordable Care Act, you can see it upticked back in 2018, 2019, 2020 level throughout that, and then it steadily declined the last several years. And this is the first year in I believe 5 years that we've seen an increase in the size of the UC pool. So for the actual distribution of the pool, what your hospital will ultimately receive, CMS is proposing to use 3 years of audited S10 data to derive each hospital's factor 3. They'll be using audited data from fiscal year 2019, 2020, and 2021. And CMS has pulled this from the December HCRIS extract, intends to update that using the March 2023 HCRIS run when the final rule is issued. In terms of interim payments and how those were calculated, they're using the average of the discharges from 21, 22, and 23. And just like prior year, CMS intends to use this methodology moving forward. They're going to use the most recently 3 years of audited data for each to calculate each hospital's factor 3. So what we would recommend is each hospital review their inputs used to calculate their payment right now. There's been some NPRs obviously issued for 19 and 20 after their S10 was audited. So just make sure that those S10 adjustments were incorporated into that NPR. Make sure all of your data inputs are correct. If there are any issues or any questions you have, we put it on the slide, the actual email address that CMS in the rule states to send any of those questions. They state even in the rule that inbox is not for questions about or an audit that went wrong or some kind of dispute on an audit adjustment. But if there's actual inputs that they have incorrectly from HCRIS, that's the inbox to submit those questions to. And then I thought I'd end with just a few updates on last year's S10 audits and kind of go over the changes from pre-audit results to actually the post-audit, and kind of look at the trend of the last 3 years from the 2019, 2020, and 2021 audits. This slide right here is just showing you the change in line 30. Line 30 is ultimately the line that drives the UC payment. You can see every year from the as filed to ultimately what was settled, that line 30 is decreasing. That percentage is actually going down. This year it was 3.5%, about $1.1 billion that were removed out of that line 30 due to these audits. But you can see the numbers of providers with a change is decreasing this year compared to, or at least 21 compared to 20. So if we kind of take a little step further and look at what made up that line 30 change, that's ultimately obviously your charity and bad debt. We look at charity. Again, you can see the trending is kind of the same from 19 to 20 to 21, but the impacts and the dollar amounts being removed from these charity lines is decreasing. The one line I'll kind of highlight in here is the insured line is still going decreasing quite significantly. I think 849 million, roughly about 26% of the amounts for those hospitals that had a revision. That's how much the percentage of their total it went down. So still a significant number of dollars being removed. And for the most part, that insured column, those have a dollar for dollar impact on line 30. So it ultimately is a big impact to your UC payment. And then kind of end on this last bad debt. Again, it's kind of a similar trend. Still decreasing year over year, but ultimately you can see that less hospitals had revisions this year. I think that's around at least 200, 230, 240 hospitals less in 2020 had revisions than 2021 to 2020. Part of that might be due to less audit sampling this past year than in prior years. These jobs are still audited. It's a huge documentation request for those audits, back and forth with auditors about situations that pop up in those templates and in those questions that they have about the questionnaire, but they did have less sampling with detailed patients. And so that might be the reason for some of these slight decreases in what some of these impacts we see just year over year. And so kind of wrap up this section, look at next steps. Right now, the 2022 audits are ongoing. So obviously just make sure you've got a designated person or vendor or staff to look at those, make sure those audits are going smoothly. And then kind of now's the time, take a deep dive into transaction codes, your policy with us coming out of COVID, with all the Medicaid redeterminations that are happening across the country. A lot of hospitals are seeing more uninsured patients than they ever have before at their facilities. So you just want to make sure, are we accurately capturing all of that, all of those dollars within the policy and ultimately within your patient financial system. And then with Transmittal 18, the new filing requirements, just to make sure if you haven't filed one of your years under those new requirements, there's a lot of new templates, new data that's required as part of the initial as filed cost report. There's even a new Part 2 section, a new S10. So just to make sure you have that covered, you're ready to support those when you need to file your cost report. So with that, Amy, I think it's time for the next polling question.
All right, thank you. The third question is, has the Transmittal 18 filing requirements been challenging for your facility? And your options are yes, no, we rely on a vendor, or not applicable. And hopefully we can move through this one pretty quickly here. And then for those of you that would like a copy of the slides, you can download them now from the console. And then we're also sending them out via email tomorrow, along with a recording of this webcast. All right, we're going to close this one out here in 5 seconds. Make sure to hit submit. And here are the results.
All right, thanks, Amy. I think this is what we see when we talk to clients as well. Certainly challenging for the ones that maybe don't think it's challenging. A lot of them are relying on vendors. And so it's just something to to take the time now, because ultimately it requires a lot of effort. So if you're looking at 630 cost reports for those with those fiscal year ends, make sure you put in the time necessary to make sure you're completing the requirements accurately. And with that, I think I'll turn it back over for our next topic on GME.
Okay. A couple things on GME to point out. CMS is distributing the additional 200 residency positions as a part of the Section 4122 of the Consolidated Appropriations Act. 100 of those, at least 100 of those, must be for psychiatry or psychiatry subspecialty. The two things here. Number one, the hospital has to show a high likelihood that they will use this space in their application. You can't bake this for later. And then number two, any provider that submits a qualifying application will receive at least one of these residencies before any other hospital can receive a second FTE slot. The maximum any hospital will receive is 10. At the same time, CMS is modifying what makes a new GME program. In this case, a new program has to demonstrate that 90% of the residents don't have any previous training in that specific specialty. If more than 10% do, the whole program will be disqualified. And so this is a proposal. CMS is looking for comment on that. And then CMS is also providing notice that there are two programs that have teaching programs that have ended with their FTE slots becoming available. Application deadline is July 9th. We're looking at about 88 FTE slots that are available. Moving to quality programs, there's not a lot of change here. The one item is the HCAPS, or the patient surveys. There's some pretty significant changes to them. As you know, the volume-based payment measures take quite a long time to ultimately find their way into the calculation itself. At this point, they're identifying that there are changes to the survey. Different questions are being introduced. Some are being modified. And ultimately, these will become effective in the survey beginning 2027. And then finally, in the value-based purchasing calculation itself for incentive payments by 2030. There are no changes to readmission calculations or hospital-acquired condition calculation methodologies. For quality reporting, which is, of course, the pay-for reporting that we talked about earlier at the top of the thing, there's 7 new quality measures, 5 are being removed, and 1's being modified. In the slides, we actually list what those proposed additions and removals are. So let's move to probably one of the bigger proposals, and that's the Transforming Episode Accountability Model, or TEAM, as it's listed in there. This is an alternative payment model. It is an episode-based payment model. It'll be effective for 5 years, beginning January 2026. And it's going to focus on 5 common surgical episodes: coronary artery bypass graft, lower extremity joint replacement, major bowel procedures, surgical hip fracture treatment, and spinal fusion. And it's going to focus on its goals are to see if the focus on episodic care will decrease program expenditures, improve quality of care, and improve outcomes. And CMS sees this model as the potential for the framework of where traditional Medicare is going to go in the future. Now, the thing that's most interesting about this is going to be a mandatory program for hospitals that are selected. And they're going to select it based on the CVSAs that Glenn talked about earlier in this presentation. They have not identified which CVSAs are going to be selected at this point. But all hospitals within that CVSA will be required to participate in this program. the acute care hospital is going to be the center of the episodic care management. They see the acute care hospital as the base for managing the care across the physician side, the skilled nursing side, the DME programs, all of the different providers involved in that episode of care. And the hospital will continue to bill under a traditional fee-for-service methodology, but there's going to be a target rate. It'll be risk adjusted and quality adjusted to ultimately identify whether there's cost savings. They'll look at the quality side and the outcome side. There's quite a lot here. There's different ways that this can be structured. There's 3 different tracks to ultimately identify where a provider's risk might be, because ultimately, if the outcomes aren't there and the costs exceed what would normally be received, or the payments received, would a provider could end up paying the program back. But there's also the opportunity for some incentive here as well. And so track 1 has no risk in the first year and an opportunity for up to 10% in additional payments. Track 2 has minimized the risk, and then track 3 has more risk but more upside. If you're interested in learning more about this program for the purposes of preparing your provider, or just in responding for comments to the program, type in team in the comment section in the Q&A. We'll make sure that you get a white paper that we've just released this morning on this particular thing that goes into much greater detail than I can do today. So again, type in team in the comments and we'll get you the white paper. And that takes us to the final polling question.
All right, thank you, Eric. So the last poll is: the proposed team is a mandatory program for hospitals selected to participate. If selected, how prepared will your organization be to implement the financial and operational infrastructure needed? And your options range from not prepared to partially prepared, fully prepared, or too soon to know. And then once you've completed your CPE requirements, you will be able to download a PDF of your certificate from the CPE progress window. And then we also email out a copy within 2 weeks as well. We'll give this a few more seconds. We're getting close to the end here. And here you go.
Yeah, this is the sneaky provision or proposal out here, because I think a lot of people are looking at it as, okay, this is another ACO bundle payment, alternative payment model type approach, and kind of ignore the fact that this is a mandatory program, and it's going to require hospitals to make some pretty significant investments to make sure that if they are selected, they can meet the moment and be successful under it. So it will be interesting as the provisions continue to be finalized. So just a couple other things. The one thing I'd point out is there's a long-term care payment rate update that comes in pretty much where we kind of anticipate 2.8%. The issue here, though, is going to be on the outlier, which is seeing a massive change to how it's being calculated and resulting in a pretty big reduction. And then there's some slight changes to their quality programs that's adding social determinants of health. Not actually in the IPPS, but that's been released at the exact same time. But I want to focus on just three things. Number one, Medicare dependent hospital status is set to expire December 31st, unless Congress comes in and extends what is set to expire. CMS is asking hospitals to provide comment on maternity care reimbursement for Medicare versus non-Medicare patients as they evaluate resource usage. and reimbursement levels on that. And then finally, there is a payment that will be become available for small and independent hospitals to reimburse them to maintain a 6-month buffer stock of essential medicines. And this would be on cost for periods following October 1st, 2024. So this will be a adjustment to their current IPPS payment to incentivize this increase in inventory. And with that, I'm going to hand it back to Amy.
All right. Well, thank you all for a great presentation today. Unfortunately, we are out of time. But to our audience, if you have further questions or comments, feel free to reach out to us and we can continue this conversation. You can drop a note in the Q&A window or reach out to the presenters directly. Also, registration for our Executive Healthcare Conference is now open. The image in the upper right-hand corner of your console will take you to more information. So hopefully we see you in Las Vegas this November. And then finally, here's a link to a survey for today's presentation. Your feedback is always appreciated. And again, thank you for joining us. Take care, everyone.
Thank you.